Let me step back just for a moment and say when we do a running evaluation on someone, we actually bring them in for, sometimes if you go through the whole program, bring someone in and they'll see Dr. Vorder for a lower extremity biomechanical foot evaluation. They'll see a physical therapist or athletic trainer for a good strength and flexibility assessment, and they'll then see the nutritionist for a nutritional evaluation, and then I'll typically end up doing a gait analysis on them. Tom very nicely went through some of the biomechanics of the lower extremities that you really need to pay a lot of attention to. I'm going to put the focus of this talk really on the gait analysis component of it and a bit of the therapy part of that. Again, as was noted just a moment ago, there's a lot of running injuries that occur: plantar fasciitis, Achilles tendinopathies, stress fractures, exertional compartment syndromes, IT band, and all the way up through the hip and lower back pain, particularly with sacroiliac inflammation that occur with running. And if you take a look at a meta-analysis done by Van Gent, it published in 2007, that if you look at running injuries for the past 30 years, there just hasn't been any big change. They're reported anywhere between 20 to 70%, with a mean of about 40% per year of runners, and it's really stayed the same through that entire period of time. So clearly, shoes and things like that haven't made a big impact in terms of running types of injuries. And if you look at the younger age group categories, which we're also very interested in terms of running injuries, one study that was reported from here using a Nurses Association study looked at girls between the ages of 11 and 17 and showed that 2.7% of them had stress fractures, and a lot of them were related to the impact activity of running as well as gymnastics and cheerleading. And then a follow-up study of that, looking at a larger number in the age group of 9 to 15, showed that almost 4% of young girls were having stress fractures, and again, related to running. So running is really a big part of what causes problems in a lot of these younger athletes, and it may be related to a number of factors. And so clearly, training errors make a difference, and we've gone by that general rule. Some people talk about that gradual 10% per increase of volume of running per week, and although that's not been fully validated, but there's a lot of intrinsic biomechanics that Dr. Vorder has mentioned. And what the most recent data over the past couple of years has been is what are the impact forces that go up the leg related to the running style, and that's been looked at by Irene Davis, by Dan Lieberman, particularly Dan Lieberman, and we'll come to some of that data in just a moment. So what actually is related to the increased impact peak, and what is the impact peak that occurs? Well, the impact peak, if you take a look at a force plate analysis of a runner moving along, you'll see this spike that occurs at the beginning of impact right in here. And this is definitely related to a heel strike type of pattern. Whereas if you take a more forefoot strike pattern, you don't have that initial impact peak, and you also don't have that rapid rise of increase in force that actually occurs there. The rise from about here onward is really just a propulsion force, and so that force probably doesn't have a big difference in terms of injury to the lower extremities. And it's that rapid rise that actually causes such a problem. So if you take a look at a heel striker, if you take a runner that runs a shod and have them heel strike in a non-shod situation, they're going to have this rapid impact peak. Well, if you then put the shoe on with a full heel, you'll get a 700% decrease in the rate, but the magnitude stays the same. And this is particularly, it's this magnitude of the impact peak that seems to be related by several studies now related to lower extremity injuries. There's been the study by Milner that looked at tibial stress fractures, associating it with this impact peak of the rear foot striker. Patellofemoral syndrome, looked at by Pohl, was a significant predictor of that, was the initial impact peak. And iliotibial band syndrome, Achilles tendonitis, and lower back pain have also been associated with that initial impact peak. not to mention compartment syndrome. And it's been sort of interesting the past couple of years of the data on compartment syndrome. But if you go back to 1983, where Kirby looked at anterior compartment pressures with manometric readings, showed that the heel striker actually has increasing anterior compartment pressures. And I think part of that is what drove them to put a bigger heel on so that you could decrease that. But it was recognized way back in the early 80s that heel striking was associated with an increased impact peak. So what happens when you're rear foot striking is you land with the knee in a more extended posture, the ankle in a more dorsiflexed manner, and your angular torque forces are highest right here at the knee, and you're landing with a very stiff leg, versus when you land with a more forefoot strike, you're going to land with a more flexed knee, and your angular torque forces change from your knee to your ankle, which can cause problems in both areas. So you have to be very careful and cautious about your interpretation of what to do with this. So in terms of heel strike versus rear foot strike, it is clear that you have increased impact peaks with a rear foot strike, but it's not clear that all people should run with a forefoot strike or a midfoot type of strike. And in fact, 15% of elite runners will run with a rear foot strike, a heel strike, and not have any significant injury patterns. So just the fact that you're a heel striker doesn't necessarily mean that you have to change someone. Particularly, I just saw a number of people over the past few weeks, high-level cross-country runners, heel striking with no injury patterns. But when you do have the injury patterns, you've got to sort of look at this whole biomechanical issue of what may be contributing to their pain. So that's one factor, the heel strike. And then there's the associated but separate factor, which is the overstride, and whether you land with your foot beyond your knee. So if you draw a line from the fibula head straight down from this significant overstrider right here and compare it against this Tarahumara Indian who's running with a more a landing pattern that's underneath his knee, there are significant differences in the kinetic energy expenditure here. So the overstrider is getting a huge negative kinetic energy force that he has to then overcome to propel himself beyond that. And this is also associated with an increased vertical oscillation. So if you're overstriding, you're going to end up having that vertical oscillation, whereas when you look at the Kenyans, they have this very straight horizontal pattern. By the way, I just heard a few moments ago that a Kenyan woman and a Kenyan man won the Berlin Marathon today, and the male won it broke a world record 2 hours, 3 minutes, and 23 seconds, which is still longer than the one Jeffrey Mutai did in 2011 here in Boston, but that one was disqualified. Anyway, so basically, you have a more of a kinetic energy output if you're getting more of that vertical oscillation associated with that overstriding type of pattern. It also stiffens your leg. Your rate of impact peak is significantly higher when landed in that dorsiflex position than you do if you land in more of a midfoot type of pattern there. And there are other factors beyond the impact peak. I'm going to come back to more impact peak in a minute, but just as we're talking about the knee, some of the things that you actually have to consider. And that is what we talked about this morning, that valgus collapse. So when you have that valgus collapse with that adduction, internal rotation in relation to the hip, this is definitely associated with knee pain, with patellofemoral, and that's one of the studies that is being looked at right now with Dr. Micheli and Greg Myers, associating patellofemoral syndrome with more of that valgus collapse type of situation. And we think that that's probably related as well as to running patterns. In terms of the hip, Carol Lewis over at BU has done a number of studies looking at women's hip pain with Gait and showing that the more gluteal strengthening that you actually have, you're going to diminish your hip pain. And what she showed was that a lot of hip adduction, again, going into that valgus collapse, or excessive knee extension and lack of calf propulsion were associated with increasing gait-related hip pain in women. So these are all the kinds of things that we want to kind of consider in our gait evaluation. Now, back to the impact peak. So we talked about rear foot strike overstriding as possibly being related to increasing injury patterns. What are the things that actually sort of enhance that or cause the runner to go into that? And there's three factors we think that may be related. One is posture, cadence and then running with a stiffer lower extremity. So posture is an issue. When one runs, running is almost more of a controlled falling type of manner, and so you can lean at the ankles appropriately, but if you're leaning at the hips, that's more of an issue. Why is that more of an issue? Because it creates an increased body torque at the hips, so that if you look at EMG studies that were done by Dowd and Lieberman, the EMG firing patterns in that lower gluteus max were higher, and the torque forces, the overstriding was a much higher tendency. This is unpublished data, but was looking at those particular trunk angles. And so what happens is that as you're moving along in your running patterns, and if you're, sometimes I can go out and take a run, I feel like I've got a really decent pattern, and then I get about halfway through the whole thing and I start to fatigue, and it's when you start to fatigue that a lot of these factors come into play. So a lot of that really is essentially training type of effects. So posture is one factor, an upright posture at the hips. Cadence is another factor, in that if you're running in a more a slower manner, because the typical jogger that's running along the Charles River is running probably at about 155 steps per minute, but as you increase your cadence to about 170 or so, you're actually running metabolically at a much more efficient step rate than you are if you're running at the slower rate. But you're also having less of a tendency to overstride, probably because you simply are moving your feet too fast to get your tibia out in front of you to overstride. And again, this has been validated, showing that your metabolic output is quite efficient, right around 170 steps per minute. So landing form is clearly important, but sometimes you can have a forefoot strike pattern. But if you have a highly plantar flex forefoot strike pattern, particularly if you actually see this, and what I see a lot of is forefoot strike, or not a lot, but an occasional. It's a little bit unusual. We tend to see some of it where you see a forefoot striking pattern associated with an overstride, and you get this sharp, you don't get the spike, but you get this rapid impact peak, and that can be associated with injury types of patterns as well. So it's not just the heel strike, it may be the overstride as well. And sort of to put some of this together, is there was a retrospective study done at Harvard and has been re-reported this year, looking at subjects, 52 subjects on their cross-country team, doing 3D video analysis on them and taking a careful review of all their injury patterns, and this was with Dan Lieberman. And what they showed was that the rear foot strikers had literally double the rates of injury patterns in the lower extremity than the mid to forefoot strikers, and they were running quite significant miles per week. So I think one of the bottom lines is landing nearly flat foot is probably best. Avoiding the extremes of either forefoot strike or rear foot strike, I think, is important. But you've got to consider that, if you go over too quickly, and I see this all the time, it clearly happened to me, and I see it almost on a weekly basis, is that you get someone to go from a heel strike to a forefoot striking pattern, you end up with more forefoot types of injury patterns, you end up with metatarsal stress fractures, Morton's neuromas, metatarsalgia, and some deep shank muscle pain. And we've actually documented in a rapid turnover like that where someone tore the deep soleus muscle of their Achilles. It wasn't a serious injury, but it was certainly painful. I actually think that's what happened to me as I was trying to transition over. So when you're retraining an athlete, it's got to be a very slow manner of transitioning. They've got to have the strength and flexibility, just like that ballet dancer has to have the strength and flexibility to go up on point. I think that the runner can't just move to a different pattern without actually having the strength and the gradual transition to actually do that. So, and then again, I would go back to the point of saying that not all rear foot striking is bad. There are clearly people out there that are rear foot striking that are doing fine, and if they're biomechanically doing okay otherwise, I think that's an issue. And then if they have a foot and ankle problem biomechanically, like a foot and ankle impingement, that's another factor that you're going to have to think about in terms of where you want to play them into this landing pattern. So to summarize, you don't want to lean at the hips, you want to adopt a high cadence, you don't want to overstride, you want to land nearly flat and quietly. Quiet is really an important thing, and you heard that this morning with Greg Myers when he was talking about jumping up and down on the stage. Being really loud was sort of a bad factor. Well, it's the same thing with running. If you're landing running loudly on the treadmill, that's probably somewhat of an issue. And then you can achieve, this fifth point is probably the most nebulous, or a little bit nebulous, is that you can achieve a lot of this by not being so stiff in that lower extremity, by having more flexibility and bend to the knee, and sort of pulling your leg up behind you rather rapidly as soon as you actually hit the ground. And this is important to really think about, particularly when you're getting tired. So when you get on our treadmill, there's a number of things that we're going to look at from a practical standpoint. So we get the video, and again, right now we're only doing 2D video. We're trying to transition that to 3D video in a short order. I think we'll get a lot more information, but this is extremely practical. We use Neuroxin, which is a fairly cost-effective way of doing it. You get a pressure plate analysis and 2D video during that time period. But what we're looking for when we get the views from behind, we usually put some markers on the posterior superior iliac spines, on the lateral side of the hip, the knee, the ankle, to sort of look at certain markers. But we're measuring vertical displacement, so you can see right away whether that head is actually bopping up and down, seeing whether the arms are tight, or particularly what seems to be associated with overstriding, because the way your foot hits the ground, if you're way overstriding, you've got to compensate by bringing the arm across the body like that. So circular motion of the upper extremities is associated with overstriding. You're going to look for pelvic drop. So what you see here is when the landing foot hits the ground, you see the contralateral side drop way down. And I think we've got an example in a few minutes on that, which indicates some gluteal weakness. But I think it's also associated with just the overstriding, because if you can imagine, you've got this huge negative kinetic impact force when you land here, which is going to drive the contralateral side of your pelvis down when you're landing there. We look for that valgus collapse, valgus knee internal rotation component. We look for the ankle to see if you're dropping into the valgus type of pattern there, or sometimes a compensatory whip, which occurs with the ankle when it has to swing out around the foot of the ankle. And then when you go to the side, you look at a number of things. You want to look again at that vertical oscillation. You can look at the lean, and he's got a fairly good lean that's occurring more at the ankle. This is a fairly high-level runner, but sometimes you'll see it leaning right at the hips where it's more of an issue. You can get an idea of what sort of a heel striker or a foot strike they have. You can look at how much stiffness they have with their ankle dorsiflexion, and how much plantar flexion they get at toe off, how much deflection they have, and again, look at their stride length. So you're going to take all of this information and you're going to give this to the runner, and you're going to make some decisions upon how you want to gait retrain them. You're going to have some information from your physical therapy station, which is going to look at different things such as gluteal strength. We do a lot of the single leg squats or step downs looking for gluteal control, manometric strength of the hip abductors, hip extensors, knee flexors, the foot dorsiflexors and plantar flexors, and the flexibility of the lower extremity as well, so that we have all of that information to sort of put into our rehabilitation type of packet there. And I think another big thing about the strength is looking at the strength of the foot. What you're starting to see more and more data come out now is the collapse of the arch and the strength of the foot that occurs and may occur with certain types of runners. And I think during your process of getting someone back to the point where you're actually having them do more of a forward to a midfoot strike, you've got to have tremendous strength of the foot. So you really want to build up those intrinsic muscles quite nicely. And those are the major issues. I'll just make one last slide here. 3 weeks ago, we just opened up the International Institute for Race Medicine, and this is a international association looking at safety in races, which looks at a lot of metabolic things such as hyperthermia, hyponatremia, and I think you're going to see more on this coming up in the near future.
Turn my stopwatch on now because I promised 10 minutes. And people know me can know I can go long on that. There's a handout included in your packet that kind of goes over these things I want to talk about real briefly here. So we're going to get started here, and I'm going to try, if I'm talking too fast, wave, but we're going to try to keep these things moving. Why do we want to understand the runner's biomechanics? Well, this is the reason here, to prevent injuries. And here's your stress fracture here. lateral fibula, often caused by oropronatory forces on this area. So really we're here to help you. You want to get you thinking about the structure and function of your athlete and what you can do to keep them, not only get them back from injuries, a lot of you are physical therapists, but as trainers, prevent them from actually seeing the doctors in the first place. You want to identify the problems early in the training and help prevent the injury. So we get to the anatomy and the biomechanical problems. The goal is to identify structural variants. I hate deformities. I don't like that term. It's because we're all a little bit, I'm bow-legged. It's structural variant that can predispose an athlete to certain injuries. Sometimes anatomical malalines can be overcome by training, braces, orthotics. Okay? For instance, this individual here, she actually was a world-ranked figure skater with this type of injury. And with special orthotics put into her skates, she could compete. And that's the way our mentality is here at the Micheli Center. And even people with high arch feet. Maybe 2 runners I knew won the Boston Marathon. One guy did 65 miles a week. The other guy did 120. The guy had 65, had very high arch feet, and really couldn't handle the high mileage. The other one had very pronated feet. So they adapted their training to their bodies. And that's what really, part of the things you guys want to think about, we mentioned here, is really thinking about the whole package, not just the injury and the structure, but the training, what they're going on. So you're being proactive here. I'll slow it down just a bit. So the first few things you want to look at is the knee and ankle alignment. Do they have any torsional issues? The leg length inequality. A lot of times what we see in clinic, people have one leg long and the other have had a fracture earlier in life. And a lot of times that long leg happens to be the one that they fractured, unless it's obviously a severe fracture. Do they have tibial vera, genu valgum, their arch height? And all these things that on a screening process can give you information that you can kind of help them gear their training towards keeping it away from injuries. One example is tibial torsion. If you look at someone, tibial torsion is the difference between the axis rotation of the knee and the ankle, roughly around 20 degrees in the adult. If you have someone who's 0, it's going to cause them problems because if you think of it, 20 degrees in an adult, their foot is slightly outturned. Well, if they're 0, they're going to be running in-toed. I like to say that, there's a 4-letter word I hate using. It's called rest. Kids come in like this, the parents think, oh, I can't do sports. Well, I tell them about a friend of mine who was negative tibial torsion, and really she had metaductus, femoral anteversion, negative tibial torsion, and she also held the American record in the marathon. Okay, so these things were overcome. She had injuries and overuse injuries and arthritis from them, but you can keep these people moving. In this instance, a lot of times when people with lack of tibial torsion will go through is a pronatory moment when their foot hits the ground and they get internal rotation of the tibia. And we were talking about ACL injuries previously. You can only imagine the stress being put at the ACL at this point. Here's the individual in your office. You'll see him on the table. The knees are pointing straight up in the air. This is what I'll do to the parents. I kind of act a little goofy in my clinics. I'll take the knees and I'll say, your knees should be straight ahead when you're running down the street. And they go, yeah, that makes sense. Well, how does that look? Good. Because they look at your feet and you'll see the feet are pointing in like this. And just to educate, the parents and the athlete. And again, here's that person standing up here. Now they look at the angulation of their knees. And you think if this person is coming down off a jump from playing basketball, for instance, what kind of valgus torque they're going to get in that knee. And again, this is a little close up there. And this is again, the same person, the oral pronation from the rear view here. Tibial vera, or like I have, if you look at the angulation of someone with tibial vera, they should be running a little in neutral in the lateral aspect of their foot. If their foot is hitting perpendicular to the ground, they can't. They're going to hit and go through a massive pronation at heel strike or mid-stance phase of the gait cycle. Something as simple as a varus wedge in the shoe will help these individuals. Okay. Different injuries you're going to see with these individuals are shin splints, stress fractures in the legs, lateral posterior heel pain or Hagel's deformity, where as they pronate, the posterior aspect of their heel is being supinated and externally rotated into the shoe itself, and you actually see holes in the back of their shoes in these individuals. There's your Hagel's deformity right here. What am I doing there? Okay, genu valgum, again, these are the things you should be going through in your screening. They're going to develop muscle imbalances you can work on as far as strengthening to help them get through their sports. Okay, IT Bandstrom in these individuals because they're putting the stress on the lateral aspect of the knee itself and patella tracking issues. Genu valgum, same thing. Working on some strengthening drills to have them avoid the knee problems. Also, something like maybe an orthotic to help control any pronation. It's not just the excessive pronation, but rapid pronation they go through during the early phases of the gait cycle. These individuals, medial knee pain from the opening up forces here on the inside of the knee, and shin splints and arch pain. Leg length inequality, this should be kind of a standard thing you all screen for. From either something inherited, you'll see that a lot of times the patient will come in with unilateral symptoms. I've had left knee, left hip, left shoulder problems. And there'll be a strong family history of this. Okay. Again, knee pain, back pain. And I also ask for the family history in that, because a lot of times these people come in, they've inherited from one of the parents, and the joke I have, it's always the father, because the mothers were always bringing the people in. But you want to say, is there a family history of this? Does someone have this issue? Look for asymmetry of the muscle development there. The next step, we move a little further down, you look at the foot itself. Do they have anything going on with the foot that might be indication of problems going on? A midfoot exostosis at the base of the first metatarsal is occurring because there's a dorsal jamming of the first ray during the gait cycle. The person's walking and running. It could be from hypermobility syndrome, it could be from a forefoot valgus, but this should be a sign there's something wrong going on there. And this isn't something you just go and take. The spur is the result of some mechanical stress being put in this person. So you want to go ahead and look at them. A simple treatment for this, you'll see these people come in who have, their shoe rubs against them, or they'll have nerve pain or tendon pain over that exostosis. Well, I tell a patient, you can go in there and take that off, but you really haven't cured the problem. A simple treatment for that is just reverse lace the shoes. And what it does, it takes the lace pressure away from the exostosis and puts it towards the outside of the shoe. By the way, I've had a lot of these injuries from my running days. I ran high school collegiately, Reebok, for a while. So I'm talking not just as a doctor end, but as the guy who's had most of these injuries through my years. Dr. Micheli has the surgical records to prove it. Other anatomical problems that affect your biomechanics, it's ones you can't see but you can detect. Okay, anterior ankle impingement. Someone comes in, chronic Achilles tendonitis, you're having a hard time treating them, and nothing seems, you're working on stretching, nothing's going on. It's because they have an anatomical block. It's not from trauma, they were born this way. A lot of times they may have an impingement like you see here, or they'll have no tail or neck. Okay, so there's no groove for the anterior axis of the tibia to go into as this dorsiflexion of the foot. A lot of these individuals see chronic Achilles tendonitis, they're doing heel work. Okay, you'll have them out running, and they're running on more in their forefoot than you would expect a normal runner to run. I mean, toe running, they could even be toe runners. And a lot of these kids, when they're younger, they say, yeah, Johnny, he walked on his toes when he was younger, because they were getting Seaver's disease, Seaver's apophysitis, and secondary to some type of ankle impingement. Here, you just need to get an X-ray. Right? But you can do that. Obviously, a lot of people don't have the X-ray at the department, so here's what you can do. You have them stand facing you, and about the feet, can you hear me here? Yeah. Feet are about shoulder width apart, point straight ahead. You say, keep your back straight, keep your heels on the floor, and I just want you to try and kneel down, like me. I go like this. Now, I usually have a little fun with this. I take the X-ray first to see if they have an impingement, then I come in and do it, and I know they're not going to be able to do it, so I'll give you $1 million if you get like me. And kids like this that can't get down. Okay, and simple treatment of that is you put heel lifts in the shoes. If you need 20 degrees of dorsiflexion during the gait cycle and you get 0, if you put them in a heel lift, you've now gained your 20 degrees. The thing about that in certain sports, like your soccer and other sports, you have a lot of motion, you can create some instability in the ankle because the talus is narrower in the posterior aspect. So then you want to get them to see a physical therapist or trainer to work on some strengthening drills there. So again, it's a multi-focused approach here. Okay, extra bone on the foot, accessory navicular. Here you can get a variation of anatomy and insertion of the posterior tibial tendon. These people can be severely overpronated. There may be nothing going on there at all. It may be something you might find incidental finding. Okay. Again, they complain. A lot of times these kids will have a lot of shin splints. If they're a skater, they'll have pain at the navicular itself. But a lot of these kids, they stand on the table. Oh, they look great. They stand up and their foot is a complete pancake. So you're going to look for a very flat foot, a history of multiple lower extremity problems, stress fractures of the fibula, shin splints, etc. And the history of what's people call growing pains. I personally don't like that term because we all grow. Usually if there's pain, there's a reason behind it, and that's what we're here to investigate what the cause of this is. Okay, coalitions, which is your congenital fusion of two or more bones. A lot of times you'll see this person will have a spasm in their foot. Okay, they come in, they'll have a perineal spasm or a perineal spastic flat foot, but not always. Okay, here's one between the calcaneus and the navicular, but you can also have seen them between the metatarsals and cuneiforms too, and they're coming out with this midfoot pain, and it's this nebulous type pain, and you get the X-ray, you see the issue there, and that usually requires some sort of very stiff orthotics to stabilize that part of the foot. Your strength and flexibility can also affect your biomechanics, and there's some gait problems that can develop. Basically, I'll go over quickly the phases of the gait. You have a heel strike, mid stance, and toe off, and the fourth phase is the float phase. And here's the diagram here, the classic diagram. Now, if you look at where the foot is quote unquote heel strike, is my alarm. So I promised Dr. Democrat I'd do 10 minutes. So I'll go real quick here. Depending on how fast a runner is running, you're going to hit at different rates. We used to train, we'd go out to Bill Rogers' house, we'd go on these 20-mile runs, and we'd be training, 5.5, 5:45-minute pace. and we'll be moving, and we'll be hitting it. Our place we would hit our foot would be a little bit different than, say, a runner who's running 8 and 9 minute miles. So be wary of that. You don't want to take someone who's like 250 pounds trying to start running out. He's about 5'2", and get him to do toe running. But on the same respect, my feeling is that a lot of runners don't do enough track workout. The people you see, the runners that come here, they say that they read Runner's World, they get a book on running, and they say, I just need to run all these miles and I'll run a great marathon. I said, no, you need to get on the track and do other stuff. And I would highly encourage all you to get your athletes, look at their training. Part of the last part of the handout here, which I don't want to take time away from these guys, is reviewing their training program. Go over it with them themselves. Go over with them and make sure they're not overdoing things or doing things that are trendy that are going to hurt them. And also look at their footwear. Is it too large or too small, too stiff? Is it the wrong last? And by the last, I just want to go over that real quick with you here. I'm going to fly through something here. Yeah, okay. Shoes have shapes to them. They have straight last and curved last. Now, your straight last tend to be called the stability shoes, which then I ask the salesperson, is that your instability shoe? Okay, or this is your motion control, so that's your lack of motion control shoe. They took straight last shoes, they decided to call it stability, and they have curved last shoes. And the last is the mold the shoe is made on. It's this plastic device with a hinge on it they make the shoe on. So it's curved and straight. Well, if someone has a curved foot and you put them in a straight last shoe, obviously you're going to have problems there. And this is the different shapes of the foot here. Okay, if you have someone on the right-hand side there, and you put them in a shoe that's really for the guy on the left-hand side, you can obviously end up pain at the... and I just had this happen the other day. The guy comes in, I'm getting these blisters near my big toe. Well, he had a stability shoe on, which he didn't need. The other thing is the flexibility of the shoe. The simple little test there. If you have a shoe that's too stiff, you're going to get the Achilles is going to be firing harder. They're going to get things like Achilles tendonitis when they're out running. Take the shoe, just put it on a table with 3 fingers, push down. It should bend across the metatarsals very easily. And for fit, because there are different foot types, you have Morton's toe, your lawn second toe. You just have the person stand up and tie their shoe up to that top hole. Some of them have a hole back there, never use it. Just have them kick their toes forward and stand there. If you can get a fingernail on the back, they're too big. Okay, people have told me their feet swell when they run, so they buy a bigger size. I said, that's congestive heart failure. Okay, it won't work. Okay, I used to run up to 100 miles a week. Your foot doesn't swell one size, okay? I come from a different background, a different way of looking at these things. I come from someone who's run, and I hear some of these things, and it's just like, my coaches, Jerry Gravel was one of my coaches, and he was back in the 70s doing the pulsing thing. Now that's become a new thing, and people buying heart monitors, which I think is great. I think we should do that. But I think with you people here, if you can use this handout I gave you just as a quick guide to go through and run it through your runners when they come in, you'll be able to really help them identify simple problems like maybe it's the shoes that are causing the problem.